welcome. Thank you. And I think everybody knows me. I don't need to introduce myself. So I'm going to talk about interventional treatment and just kind of, some of the, we do have a lot of new people coming in and out. So it's kind of nice that everybody get a little refreshing course of what we do. And also there's a lot of, the field of pain management always evolve. We're always advancing. We're always looking for new technology, new ways of treating pain. And we're gonna get into some of those details too. So probably by far the most common thing that we do is epidural. We order a lot, and most of the people coming in is like, I want an epidural. Like, what are we talking about? So epidural is basically indicated for a lot of patients with anyone with sciatic pain, or basically indication for patients suffering with neurogenic claudication. So some of the most, this is a picture of, there's two approaches to doing interlaminar, doing the epidural. One is in the interlaminar approach, which is this approach. And the other one is the transforaminal approach. So the interlaminar approach, we put the needle right in the center between the lamina. This is right at the L4-5 level, and you can see it from the side view with the contrast eye showing very nicely the spread of the contrast in the kind of like right behind the posterior aspect of the spinal canal. And the other one is the transforaminal approach that we order. And that's basically, most of the surgeons really like that because it's very specific. It tells them specifically that's the nerve that's causing the problem. So, sometimes I do have patients that find the other approach, one approach works better than the other one. Next is joint injection. There's really two major joints in the spine, the facet joint and the sacroiliac joint. So this is a picture of the sacroiliac joint. You can see the dye spread really nicely throughout the sacroiliac joint. The facet joint, the way we treat facet joint now is most of the time we perform what we call radiofrequency ablation. And initially we started with the medial branch block as a test block that we order. You can see the needles were placed on the right-hand side next to the facet joint. You can see the facet joint right here. So there's actually a nerve that runs medially, kind of wraps around medially into the facet joint this way. So that's why it's called a medial branch. So by cauterizing that nerve, it will help to mask the symptom anywhere from 6 months to 2 years, or some people even longer. And next would be sympathetic nerve block that we perform. And it's actually not as common as in this practice. So sympathetic nerve block, we have the sympathetic chain basically running all the way from the lower cervical, extending all the way into the coccygeal area. So in the cervical area, there's the stellate ganglion, one on each side. It's indicated for patients suffering with complex regional pain syndrome in the upper extremity. And then we have the lumbar sympathetic nerve block that's indicated for a patient suffering with CRPS or complex regional pain syndrome in the lower extremity. And then the celiac plexus nerve block, I used to do that more often. Patients have suffering with chronic upper abdominal pain. Most commonly seen were chronic pancreatitis, pancreatic cancer, really helps with their pain. Basically anything above the umbilicus, then you can perform, we can perform celiac plexus nerve block. Hypogastric plexus nerve block is more indicated for patient with suffering chronic pelvic, lower abdominal pain. I have a patient that I'm still doing it for her with Crohn's disease, and before she met me, she was having pain going to the ED almost every month for Crohn's disease, for flare-ups. After doing that, there was a year she went like maybe 3 times instead of 12 times, so it really helped them. Ganglion impart is indicated for patient with tailbone pain, rectal pain, anal pain, rectal cancer, so quite effective. So, and this is just an example of how we perform the lumbar sympathetic nerve block. This is the front view. This is how it looks on the side. You can see the ganglion right here, and then this is the chain. And last is we're gonna get into the more advanced stuff. So probably by far you hear the most is the spinal cord stimulator that we perform. So basically the way how it works is neuromodulation. Just like the name say, it modulates the neural pathway. So when the spinal cord stimulator get turned on, it will modulate the pain signaling from the brain radiating down, so the pain will be modulated, so it's the patient will perceive less pain. This is a little history. There's pretty much a long history of the use of electrical current. Back in ancient Rome, ancient Greek, there's already documentation using electrical current for treatment of pain. You can see they were using torpedo fish for treatment of gout and also headache. I don't know how helpful that is, but that's the history of it, at least. And how, the pain pathway, basically, to keep it simple, the brain send the pain signal traveling down through the 8 delta and C fiber. C fiber is primarily for chronic pain. C stand for chronic, so easy way to remember it. But when that way, the patient will perceive pain. So spinal cord stimulator they activate these 8 beta fiber, at least theoretically they activate them. And these inhibitory neuron will trigger an inhibitory response and therefore decreasing the signaling through the 8 delta and the C fiber and therefore reducing pain. That's a picture of how when we perform the placement of the spinal cord stimulator, that's how the leads look like on the fluoroscope. And of course, the one that we perform that we use is the wire lead, the percutaneous lead. Some patients, they have the paddle lead, which is performed by a surgeon. The disadvantage of that is, of course, you need a surgeon to actually do a laminectomy. So it's a little bit more invasive, but the advantage of that is there's always the risk of migration with the percutaneous lead, but the risk for paddle lead is much, much lower. And these are some of the IPG, the power source of some of the spinal cord stimulator. And they basically look just like a pacemaker because the origin of spinal cord stimulator is actually coming from a pacemaker. So nowadays it's becoming smaller, thinner, rechargeable, non-rechargeable. When I first started here 7 years ago, it was only one company that's MRI conditional. Now all the companies are MRI conditional. Some of the new companies are actually incorporating AI technology, which is really cool. It's actually, they claim that it's actually the device is learning how, the patient's daily activity and therefore modulate and program it to fit the patient's need. And some of the newer advanced intervention treatment that we are starting to also introduce and also offer to our patients is sacroiliac joint fusion. So there's traditionally the sacroiliac joint fusion was performed by the surgeon. As you can see from this picture right here, that's the traditional way of doing it. Basically, you put 3 rods kind of laterally, you transfix it through the ilium into the sacrum. The disadvantage of that is there's always a potential of injuring the neurovascular bundle. There's going to be some type of bone trauma because you kind of puncturing it into the ilium and the sacrum. So longer recovery time, more painful because there's more dissection of muscles. Over the past 10 years, the posterior approach is more common now. It's something performed by both, I've seen it, both surgeons as well as us, interventional pain management will do it. Basically, you put the trocar, like a tunneling device following the trajectory into the sacroiliac joint, and then you deploy the implant in there. So in and out surgery usually takes about 35 to 45 minutes. They go home the same day. Small incision of 4 centimeter. I just saw one like literally right before I came here, and she's 1 month out. She's 90% better, and she can't wait to do the right side. So it's working out for her really well. So. And also the advantage is, again, short recovery, and there's a minimal risk of affecting or injuring the neurovascular bundle, and also there's no trauma to the bone to some degree. So, and of course there's two types. The one that we use is the titanium construct. And of course the other one is more like a small implant that put it in. This one actually deploy an anchor and actually transfix the sacroiliac joint, facilitating a fusion. Other advanced interventional treatment, stem cell therapy, PRP injections, probably a lot of you heard about PRP. Stem cell is more common. A lot of time when I talk to my patients, I said, PRP is something that we offer. They would be like, they have no clue what PRP is, but then I'll tell them, hey, you heard of stem cell? Almost everybody heard of it because it's been around for at least 20 years. So, but the way how I tell patients the PRP is always like a dirty version of stem cell. PRP has been around for about 10 years or so. And it's a newer form of regenerative medicine. So instead of aspirating the bone marrow from the iliac crest, it's less invasive. You draw venous blood, centrifuge it, extract a layer of high concentration of platelets, and then inject it into injured tissue, bones, actually not bones, but more like joints, bursa, tendons, muscles, and theoretically it triggers a cascade of event of repair mechanism, bringing the cytokines, the fibroblasts, the growth factors to heal the process, to repair the damaged tissue. So the data right now is great, usually anywhere from 12 months to 24 months of relief. And what I see in my clinic, if it works, they tend to last for several years. But I do tell the patient that, it's not cortisone. It's not going to work like right away. It's going to take like a month to 2 months to start kicking in because it is repairing. It's a repair mechanism. So I do have patients that just like 1-2 months, they're like, oh, it's not working. And then by the time I see them 6 months, they say, well, I really don't have pain anymore. I'm back to playing golf. I said, great, I guess I'll see you as needed. So stem cell, similar, other than it's more expensive, usually much more expensive, but the concept behind stem cell is still repair, but theoretically, the advantage of stem cell is that it actually differentiates into the tissue that we're supposedly differentiating into the tissue and replacing them. So it's not other than just repairing, it's actually differentiating into the tissue and replacing. But, what's the data behind? I mean, the data has been about like 50-50 right now. So, but, a lot of people are interested, it gives our patients hopes that it will help. And I do have patients that actually have stem cell injection that actually have good outcomes. So. And I think Dr. Casson put in a lot of effort into that and kind of putting together a little stem cell protocol. So looking forward to that. Other new technology that we are bringing abroad is, one is the basovertebral nerve radiofrequency ablation. The concept behind this is it's really FDA approved for vertebrogenic pain. So most of the people will have pain when they have forward flexion. On MRI, they will see modic changes, basically degeneration of the disc, creating inflammation around the disc. And I have a couple of patients coming in from our surgeons, and they're really not surgical candidate. And they went through stuff like epidural radiofrequency ablation, and it didn't really work. And so this would be a great concept, basically putting in kind of like not a trocar, but like a probe. That's right, a probe through the pedicle into the vertebrae, kind of like when I was doing balloon kyphoplasty for my patients for fractures. When it went into the vertebrae, and then it will generate heat, basically deliver radio frequency and destroy the nerve, and therefore a patient will have good relief from it. Usually takes about 15, 20 minutes, 30 minutes at the most, in and out procedure. Patient go home the same day. It's not, there's no surgical incision involved. It's just basically numb them up and then put the probe in. So. And last but not least, multifidus stimulation, something that that we are also looking into bringing on abroad is it's kind of like a stimulator, kind of like spinal cord stimulator, but the concept behind the problem with spinal cord stimulator is it works great for patients suffering with sciatic pain, but low back pain is kind of like a little hit or miss, even though there's some good data showing that it works for low back pain, but it's kind of hit or miss. But FDA approved this in October of last year for patients suffering with chronic low back pain. And the concept behind is that people with, whether it's mechanical or non-mechanical low back pain, they're suffering with low back pain because there's degeneration of the multifidus muscle. So it's the muscle that kind of runs exactly kind of like posterior, like kind of on the side right here along the spinous process. So, so the concept behind it is by putting the leads around those muscles, it will cause contraction and therefore reducing the pain. So it's a pretty nice concept behind it, especially with our current technology, not really anything that really effective for patients with non-mechanical low back pain. That's it, but the field of pain management is always expanding, so there's going to be more and more of these interventional treatment coming out, and with our aging population, a lot of our patients are not really a candidate for a lumbar spine surgery or anesthesia. So these procedures in and out, 35 minute, 45 minute, they go home the same day, great outcomes, minimally invasive. So the demand for these procedures are high, so I foresee there's just more and more of these procedures coming out. I mean, there's other ones like Minuteman, Vertiflex that we didn't really talk about here. So so it's exciting that, probably in 2-3 years, we're gonna give another talk with more new technologies coming out. So that's it.